is an assistant clinical professor in the College of Optometry at the University of Missouri St. Louis. He teaches a telehealth course that he created there. He has guided the development of a new Teleretina service at a university-affiliated federally qualified health center and serves as chief attending at Affinia Healthcare. Dr. Nabhan also does research on new telehealth hardware solutions and mobile processing devices. These are hard words for me today. I don't know why. He currently has a focus on collaborations with Computer Science, Walking Shield Inc., and Indian Health Services. He has served as lead optometrist on more than a dozen charitable, sustainable humanitarian eye clinics in China, Peru, Thailand, Jordan, Brazil, and Missouri. And he guides the development of and scalability of electronic simulation training tools, providing blended learning opportunities that support workforce development opportunities in academia and underserved communities. And he is committed to supporting UMSL's Anchor Institute initiative with involved stakeholders to provide long-term, meaningful solutions. Welcome, Tareq.
Thank you. I realize that's been written a while ago. Yeah, so some of it is not current with our relationship with Walking Shield, of course. That was pre-pandemic, et cetera. But thank you, Rachel, for this opportunity to be with this group. And I see Karen in the audience, and I certainly appreciate her contributions to the telehealth course. She has guest lectured in the course, and it's just wonderful to see that expertise added in as telemedicine brought them. Although she's a specialist, and so she can do all these things. It's just wonderful. Additional appreciation to Omari for the emails and all the coordination required. Thank you for that. And then for the rest of the team for being here. So I'll just jump in. You saved me, I think, a slide, Rachel. Thank you. Can everybody see my presentation? All righty. Okay, so I'm going to talk to you guys about Teleretina in the primary care setting. When we look at optometry ophthalmology, one of the most common services in the telehealth space is going to be Teleretina, and I'll have more material about that as we proceed. This is a slide that Rachel has already covered. One thing that I'll add is I do work for the government now for the Centers for Medicare and Medicaid Services on their MedCAC committee. It's really an honor to be involved in that capacity. And just a couple weeks ago, I was asked to serve on the Vision Services Committee for the ACU. Yeah, Teleretina. So here we go. Teleretina in the primary care setting. This is key here. And some of the topics we'll talk about are the prevalences and incidence of diabetes and diabetic retinopathy. The concept of imaging is the gold standard. This presentation did change, Omari, just slightly from what you guys had reviewed. So I can send you this updated version. Some of the imaging indices of various technology as you try to make a decision about what tool to use in your Teleretina services. We've heard the Missouri Primary Care Association come visit us. We've been working with them fairly closely on what Teleretina can look like. I was just invited to lecture at their annual conference in October in St. Charles. So just exciting stuff. So if you're thinking about what Teleretina can look like, I think we'll get into quite a few of the particulars that will make it a thoughtful program. We'll talk about cost effectiveness, meaningful use metrics like HEDIS, and then the setup, service, and screening considerations. I always start off this presentation by just talking about the problem. When we talk about Teleretina in the primary care setting, the low-hanging fruit that addresses the majority, not the majority, but a significant portion of the issues that are out there is diabetes and diabetic retinopathy. With diabetes, half of the world, or 500 million people in the world are diabetic. Half of them don't even know that they are. In the United States, 37 million Americans, that's 1 out of 10. Americans experience diabetes or have diabetes. If we include the pre-diabetes numbers, we're looking at just around 90 million people that are 18 and above. So that puts 1 out of 3 Americans as diabetic or pre-diabetic. Diabetic retinopathy is the leading cause, and I use this line daily, and I don't do it as a threat of any sort. Or as fear-mongering, but it just brings out the seriousness of the issues because that's facts on the ground. It's the leading cause of blindness amongst working-aged adults in the U.S. And around 20% of type 2 diabetics will have some type of eye involvement at the time of diagnosis. And sometimes that diagnosis is after having had an eye exam. We know that diabetes is not born equally. We have certain races and sexes who are affected more. And we know that diabetes does not die equally. We can look at mortality disparity amongst different races. We know that the prevalence of diabetes is going up, but we're getting better at detecting it, of course, just as technology improves, as screening measures and programs improve, and then as an aging population, we see that the prevalence continues to grow significantly. If we look at a pandemic within a pandemic, I know that you all understand that diabetes is a pandemic, but if we look at some meta-analyses and pooled population studies looking at diabetic retinopathy as a complication from having diabetes, we see that around 25% of type 2 diabetics in these hundreds or tens of thousands of people involved in these studies, 25% of type 2 diabetics had diabetic retinopathy or more. And then for type 1, when they were studied in these meta-analyses, around 75% of type 1 diabetics had diabetic retinopathy. So a pandemic within a pandemic. If we look at the workforce burden put on optometrists or ophthalmologists and just break down the numbers, I do this in my class, and I think it's been helpful for students to understand, especially as new technologies coming in, to really establish that culture of understanding of how we work with technology. If we look at 37 million Americans, that's 74 million eyes, or just over 200,000 eyes that you'd need to see every day, or just under 9,000 eyes an hour, or 141 eyes a minute. That's 2.4 eyes per second that need to be seen every day, 24 hours a day, 7 days a week for a year, at least a year, just for us to keep up with those numbers. So that's a burden that we can't keep up with, and we're not keeping up with 50% of patients maybe not even showing up for it. So it's a problem. Now, the thing that I found very interesting that is helpful is there was an observational Danish study looking at over 100,000 patients and found out that around 14% of those patients had some evidence of diabetic retinopathy lesions. So is there a pre-diabetic retinopathy? I think just every clinician on this call will say, no, there's not a pre-diabetic retinopathy. It's just diabetic retinopathy. And so whether we put numbers on it or not, when the body breaks down, the body breaks down. So here's what treating end stage or more advanced diabetic retinopathy looks at. When I give this talk to high school kids, they tend to, you hear them in the crowd saying things. No one wants to get a needle in the eye. This is an Avastin or Lucentis or any anti-VEGF injection into the vitreous of the eye to treat these new blood vessels that have grown. Now, these darker blood vessels that you see here, that's part of normal fetal vasculature, but all these other ones is a consequence of neovascularization. And that angiogenic potential can be helpful in some disease states, but it's not helpful here. And it's probably not helpful in most disease states, but I'll leave that to the experts. But in the eye, it results in significant collateral damage. It's not helpful. And so these injections are. But the question is it was Shakespeare, I think, who said, the superior doctor is the one that prevents disease. And then we all understand that the next best is the one that can catch it early. Can we use Teleretina in the primary care setting to do that? If we set up a camera in the primary care office when patients are getting into their eye exam, their medical exams, but not being able to get into their dental or podiatry or eye exams, we can capture them right then and there and send those images over. Here's a picture of me with several of our students on a large screen where you get these retinal images to come in and you can evaluate them together, having some pedagogical value in that experience as well. So can we do that? Yeah, the VA's been doing it for more than 22 years. Indian Health Service is about the same in NASA. And one of the speakers in my course is the chief of eye care at NASA, because part of that motivation is the culture change. Again, you get these students that come in and they're thinking, oh, just private practice, this is what I want to do. I want patients in my chair, and that's a good thing. But we're talking about patients that aren't being competed for, or patients that are completely inaccessible, like our astronauts. So when our crew members are aboard the ISS and there's not a physician on board, what happens? So NASA is a really good program, and I think that helps us terrestrialize the solutions that have been around for more than 2 decades already. Here's a case I share often. This is a normal eye and a diabetic eye, and for any optometrist or ophthalmologist that sees this, they can tell you that is a diabetic retina faster than we can read that says diabetes or normal. In fact, we can tell you the level of diabetes that we see in that retina within seconds. So I don't want to geek out here, but I have more than 20 hemorrhages in the superior temporal quadrant. I have more than 20 hemorrhages in the inferior temporal quadrant. If this is not a vascular occlusion, then it's not likely that the superior nasal or inferior nasal quadrants are immune to that. So I already have severe non-proliferative diabetic retinopathy with all of these exudates here, this yellow lipid and proteinaceous material in the macula. For you to have that much of that is clinically significant diabetic macular edema or center involved. So without seeing much, I can make a fairly good diagnosis on the level of damage here and know that this is referable level diabetic retinopathy. Are we good at it? We know that in our curriculum, the National Boards for Optometry, which represents 2/3 of all primary eye care in this country, is tested on this. So all of National Boards Part 2 is telehealth, no matter how you look at it. So they look at retinal photos, corneal photos, cataract photos, some brain scans, and they're supposed to make diagnoses on these images or on these cases. That is by definition telehealth. So our National Boards Part 2 and our proof of competency of our students is by definition through telehealth. And so they're pretty good at it. At least that's the goal. Is the technology good enough? Today, we have solutions that capture 45 degrees of the retina. Now, these were developed way back, but they're still around today. And I don't want to jump the gun here, but some of the issues that we have with people onboarding these solutions is it's only capturing around 15% of the retina, maybe 20%. Today, we have solutions that do this. You get 82% or 200 degrees of the retina in a single capture. Those white circles are actually 30-degree retinal pictures that were done to develop a hallmark study for the early treatment of diabetic retinopathy. And so now we have tools that image way beyond that, changing how we even potentially classify diabetic retinopathy and diabetic retinopathy risk. So you can see out here in the periphery, and then over there in the periphery or inferiorly there, you have hemorrhages that aren't even picked up in the traditional scanning zones of the retina. So if we're not even looking in those zones, we don't even know how to classify risk until now. So now the Diabetic Retinopathy Clinical Research Network looked at peripheral diabetic retinopathy lesions with the rationale that this evidence could help us change how we manage patients and give us some insight into the disease mechanisms. And if we have these solutions that we can image and get more of retina, if we can do that in the undilated eye, maybe we can make patients more comfortable and improve workflows. So this is what that looked like. On the shoulders of the giants before them, they took the EDTRS, which were these 7 standard field images, and said, well, now we have technology that'll image everything without having to do 7 separate photographs. It's just one photograph done in seconds that captures 82% of the retina. And now we have these peripheral fields that we didn't have before. Let's include those and let's do a study to see what that can tell us. And so they did. And what they found out is the grading of the undilated images capturing 82% of retina demonstrated high agreement with the grading of dilated EDTDRS photographs and that of dilated in-person fundus exams. So you have this level of agreement that's very important. And then you had the ability to apply this to both research and clinical settings with the added benefit that it's faster in image acquisition and it can be done in the undilated pupil. Moreover, they found out that when you had these predominantly peripheral diabetic lesions, that your risk of progressing into 2 stages or worse of diabetic retinopathy over 4 years was increased by more than 5-fold. So now we image the periphery with better tools, and we understand that there is an added additional risk of progression when you have these peripheral diabetic retinopathy lesions. If we look at non-mydriatic, so the traditional undilated fundus photographs that we're capturing the 45 degrees versus the non-mydriatic ultra wide field getting the 82% of retina. When we look at image gradability and compare those, around 20% of retinal images. Now, this is the make or break. If you take anything from this lecture, the make or break of a teleretina screening program is the image quality. If 20% of your images are not gradable, that's pretty high, but it's also pretty high that more than 80% of your images are gradable. But with the ultra wide field solutions, now we're talking like 94% of images are gradable. And the time significance it's not even, you can't even compare the two. One is done in literally just a second versus the other one having to image the eye 7 times. And that's quite uncomfortable for the patient to have to go through 7 flashes. And again, if you flash an eye that is not dilated, that flash will bleach the retina and make that pupil really, really small, making all subsequent images quite poor. So a one and done is the way to go. And that's really just addressing a needs issue that's been satisfied with this solution. So yes, the periphery of the retina does matter. Evaluating multiple studies, they found out that the majority of lesions for retinal disease happens outside of 60 degrees of the retina. So when you image just the center, you're missing a lot of disease in the periphery. You have a 5-fold increase of having 2 stages or worse diabetic retinopathy when you have predominantly peripheral lesions. And I include this slide for all clinicians on this call. Whenever we use the handheld ophthalmoscope, you see these in the primary care offices often. This is how much of the retina you're seeing. You're seeing about the size of the optic nerve. When you use the binocular indirect, you may see that your eye doctor wears this thing on their head. You're getting this yellow circle. It's around 30 degrees. A traditional fundus camera around 45. More advanced wide field solutions were capturing around 100 degrees, and now the ultra wide field capturing 200 degrees. So just incredible technology. It's just redefining how we grade diabetes and again assess risk. Now, I include this because I think it's important whenever we look at 2D images. How good are we at being able to identify areas where there's thickening or elevation? And we're not good at it. We're okay at it, but we're not great at it. And so with diabetes, we have these findings that are considered referral level. So as optometrists, we want to be really good at this. I want to send a patient when it's time for when there's an intervention required, not because I don't know, but because I do know this is medical legal practice. When I find this is when an intervention needs to happen. And so these are the definitions of clinically significant macular edema or center-involved diabetic macular edema. And the standard of care is the slit lamp biomicroscope. This binocularity allows us to see tens of microns of thickness. So when you're trained at it, you get pretty good at it. And so that's the standard of care. And if we look at how good we are looking at non-stereo digital images in terms of a teleretina setting, being able to identify clinically significant macular edema, we're not that good at it. We're just a little bit above 50%. So not much more than a flip of a coin. But when we use other cues, so if we see more than moderate diabetic retinopathy lesions, whether those are dot blot hemorrhages, cotton wool spots, etc., we're better at being able to say, yes, there's clinically significant macular edema. But there are tools that can help us do this without us having to really do that. Now you have tools in optometry and ophthalmology that'll take a photograph of the eye and do an ultrasound scan of all of the retinal tissues. So this is retina cut sagittally. And you can see just, the actual layers of retina here. So this is a very impressive solution that's been developed. And it's essentially democratized into most optometry and ophthalmology offices. Just about everybody has an OCT now, an optical coherence tomographer. Now you have these solutions that are embedded in some of the the solutions that now capture the 82% of retina, what they're embedded with the OCT. So these are combo units that occupy a smaller footprint and just are just very, very powerful tools. I include this slide a little outdated, 2019, but it's just so we can be that we understand what a diabetic eye exam in terms of the meaningful use metrics, or if we're meeting our performance metric. The current standard is a dilated retinal eye exam by an optometrist ophthalmologist. So this is CMS language. If you don't have an optometrist or ophthalmologist, did you use the 7 standard field images that have been studied and validated to be good? And if you didn't, did you use an imaging solution that's been validated to be just as good or better? And I think this is where, if you're listening to anything else on this presentation, it's that a lot of the other solutions haven't been validated. And that's the position that we take as eye care providers who are advocates for our patients, is to say, if you're capturing only 15% or 40% or 60% of retina, but knowing that 66% of lesions exist outside of 60 degrees, then we're missing all those. That's not validated. And so that's our position, is to look at validated technologies. And this is what Jocelyn Vision Network in Harvard, or the Diabetic Retinopathy Clinical Research Network, has been doing for a number of years now, is looking at how ultra wide field is impacting eye care. And it's doing it so much so that it's actually redefining how we classify risk. So here's that image. You have this 30-degree field that you're picking up here of the optic nerve and a little bit of the macula. This is what a 45-degree would look like, a 60-degree would look like, a 100-degree would look like, and you can just see that you are trumped by every one of these missing those peripheral diabetic hemorrhages out on the temporal periphery over here. And so with the university, in partnership with the Finiak Healthcare, where I'm at today, where I get to serve as one of the attendings, we have developed and helped guide the process of what Teleretina looks like. Finiak Healthcare is just an incredible program. I brag about them all the time. They have actually more than 14 locations with all of these multidisciplinary settings, serving 200,000 service encounters per year for about 45,000 unique patients. Around 70% of our patients identify as Black or African American. 90% of our patients that we serve here are 100% below the federal poverty line. 45% are uninsured, making Finiak Healthcare the largest provider for uninsured patients in the entire state. 10% of our patients are experiencing homelessness. I need to change the language on that slide, but that's the better way to word it. And then it's wonderful because we have a partnership with the International Institute. So we get to see a lot of patients who are refugees or asylees from Afghanistan, Iraq, Palestine, you name it. We get to see them, and it's really an honor for us to democratize our solutions to everybody. And so this is what our strategy looks like. We have Affinia in the university. This is my office. We've identified the camera that we want to use and our pass-fail criteria, where it'll go. You find the sites you want to visit. If it's a mobile solution, we get our images that are acquired by the medical assistants at those remote locations. You must define your pass-fail criteria. Now I removed several slides just because the lecture would have been too long about setting up your pass-fail criteria. That is critical. If you fail everyone who has any small hemorrhage, you're going to be seeing a lot of people, and that's quite costly. If you look at some of the solutions that are getting FDA approval, they're usually getting approved for more than mild or more than moderate diabetic retinopathy. So please reach out. We're here to help, but know that your threshold will be key. And then we have our codes that we understand that we can use. These are average reimbursements, probably a few years old now. And then the reports are sent back to the primary care setting. Now with our referrals, so those urgent cases that need referral, we just deal with those right then and there in real time. With the ones that don't need to be seen back, those reports are sent back to primary care for communication with the patient. So yeah, Teleretina screening for diabetes is a proven process. It does improve access, awareness, and affordability. And for us, it has a pedagogical benefit to keeping our students part of the process. We know that multiple players have skin in the game with improving HEDIS metrics and meaningful use metrics for our patients. It's a win-win-win for patient, for provider, for student, and for the organization. And we know that having primary care just tell patients to go get their eye exam isn't enough. We really got to get the patients while they're there. When you are considering setting up teleretina, you want to be thoughtful of the patients that you see, the number of patients that you see, the number of patients that are diabetic, and then their ages. If these are kids, that's a different thing. We are always thinking about that with our humanitarian work. If we're going to this place to do eye exams, who's it for? If it's for adults, that's one thing. If it's for kids, it's another. Setting up a realistic goal for your teleretina screening, and then having the support from IT, understanding how it works with your workflow, the interfacing or integration with your EHR system, and then your PACS imaging modality, and then understanding if this could be a revenue stream for the organization. Other considerations are understanding the standards of care. And I've highlighted this. I'm not a careerist, but it looks like it when I do this. But if you don't have an eye care provider part of the process, this is just anecdotal. A lot of cameras at a lot of these sites through the Missouri primary care, so they're just collecting dust because they want to pick up these handheld or these portable solutions, and they're fast and it's undilated. And the whole process of putting in an order, image acquisition, gradability, what does it look like in terms of turnaround? It just ends up being a nightmare, and they just end up not using those solutions. So please keep a clinician, an eye care clinician, as part of the process. Again, our students are educated in this. That's why we have the course, and most optometry schools have content related to teleretina and teleoptometry, teleophthalmology. The other one that's important is also understanding liability, like who's responsible for anything in terms of imaging, who's carrying the license or the malpractice insurance. Is that a contracted situation? Is it an employed situation, et cetera? And then jumping into AI, well, coding before AI is there are codes for teleretina. Now, the 92227 is for the screening of patients with no known retinopathy. That's the 227. The 92228 is for those that have retinopathy. And I add these just to make it simple. That's kind of how simple it is. You have modifiers, but bundling those and just having it contracted out the way that we have it set up in others is that they just do all the billing, and you just have a contract or an MOU in place, and then you deal with it that way. But I have this in red. The 92250 is not teleretina. That is image acquisition in the office like us here, where we have optometrists. We are using our camera solutions to photograph the eye. That's just, that's for good practice and for documentation. It is not for remote care. That may change depending on what the commercial plans are defining, but that's generally the case. And I'll add this last one with the 92229. There have been actually the first FDA approved AI system in healthcare is in ophthalmology, and that's Michael Abramoff at the University of Iowa with digital diagnostics, formerly IDXDR. They developed an automated analysis system, an autonomous system that will grade diabetic retinopathy. And so that is a reimbursable measure. Now, I'll include this because it's just important as things continue to advance. We're trying to find out how we can work with technology, not be against it, but also have a position on it if it's not effective. And so Aaron Lee is a retina specialist and a computer scientist at the University of Washington in Seattle. And he had the first paper that came out looking at the validation of AI systems for the autonomous detection of diabetic retinopathy. He took 7 of those systems and compared them and found that they didn't agree with one another. So if one grades diabetic retinopathy as mild, the other graded it as moderate, the other would say severe, the other would say none. That's not good. That's not good because your follow-up or your management for that patient can be very different depending on those scenarios. So And then what's worse is what if it grades it as a non-severe, non-proliferative, but it ends up being actually proliferative. So when they don't agree with one another, that can be very dangerous to patients. So the technology is going to continue to improve. We want to find out how we can work with it, of course, but it's all backed and rests on validation. And if, again, that's the position that we're taking in our course. That's the position that we take in healthcare. It's always looking at evidence-based healthcare and best practices. Looking at Teleretina, looking at the solutions, et cetera, is not immune to those validations and those requirements. And so some solutions are better than others. We'll just find out how we work with it. I felt like I flew through that. I probably needed to, but that is Teleretina in the primary care setting, and I'm ready for questions.
That was such a really great talk, Tareq. I really appreciate it. I have some questions, but I'm going to let other people jump in with their questions first. So just unmute if you have a question and feel free.
I have a question about the billing. Did you see shifts during the public health emergency related to the services that you could provide, or any shifts in allowables, if you will, within the guidelines? And now that it's ending in May, are you seeing any shifts back to the way it was before, or did they adopt some of these things as best practice and they want to continue to support it?
Great question, Molly. Thank you for that. Yes, there were a lot of waivers, with being able to use a telephone or Skype or FaceTime, so as you guys know. But I focused this talk on Teleretina because they didn't change with Teleretina. But with teleoptometry or just telemedicine or telehealth in general, yes, the waivers applied to everybody, including optometrists. And so, yes, those waivers were in place. And when we first reopened because of the pandemic, we did build our own teleoptometry service. So I helped develop an app through one of the largest eye care nonprofits at the time that would allow people to go into a website and screen themselves. And what we did, instead of them screening themselves, is I actually enabled screen share through Doxy.me, and there was a credit card that's on the screen that they would size their screen. I would size their screen until they told me their credit card matched the screen credit card matched their credit card. So if I'm doing it with you, I just minimize the screen or maximize the screen until you said, yes, it's now the same size as my credit card. Now I've calibrated the screen to assess your visual acuity. So I'd have you step back 3 big steps, so around 3 meters, approximately 10 feet, and measure your visual acuity. And we could do all those things. And those waivers allowed us to do those things. But in Teleretina in particular, no, I didn't see any changes to that. It's so well established with the VA 23 years, IHS 22 years. You just had to get it set up.
Thank you.
Who else?
Sorry, hi, Tareq. This is Tim. Yeah, another great presentation. I know Tareq has helped me out with the Telehealth Alliance of Oklahoma presentation, and yeah, he's wonderful. So this new technology, of course, is wonderful, but what kind of price increases or costs are associated with this? 200-degree versus older traditional, maybe 90 or 100-degree.
Yeah, good to see you, Tim, and thank you for those words. I was thinking this could be boring for you, knowing that you've already heard some of this. But yeah, that's a wonderful question. Now, the Opto solution that I showed you that does the OCT scans as well, so the photograph and the scans, that's very pricey. I don't want to speak outside of capacity, but many tens of thousands. But they're smart, and they recognize with their proprietary information and solutions that this 200-degree, 82% of retina doesn't need to have that feature embedded in, if we're talking specifically about Teleretina. And so they've developed solutions called the Optos Primary, and that's what we're onboarding here. And we're looking to scale that. That's around, again, you want to talk to your rep, but it's around 40 grand. I know that you can get other solutions that are under 10 grand, but those are just the solutions that we see people not using or not working for them, and that gets costly. Now there are ways, and you can always talk to Optos directly, etc. But they do have programs where they'll build out an interface with your EHR system, or you just use their DICOM feature that just sends that image into your image review modality like you're using for radiology, and you read it. There's no additional cost there. So you're looking at around 40 grand for some of those really good solutions. The ones that are in the under 10 grand tend to be worse. I don't want to say it that way, but you don't get as much, and then you're missing a lot of disease.
Sure, understand. Thank you.
Thank you.
Good question. That was one of mine too. Okay, who else? Anybody else? I've got a couple, but I'm going to start with this one. I heard you mention that in some of the maybe a health center that had that machine, Tareq, that maybe a medical assistant would be taking those pictures. How long does the training take for that medical assistant to use that device to be able to get to a level of they're doing it right, like almost every time?
Yeah, that's a wonderful question. The studies looking at these solutions were done using high school kids, who have no formal medical training. That's number one, and it was shown to be very effective. At the optometry school at UMSL, when we have our second years doing their emerging technology assignments, it's one sitting. They learn how to do this. They'll position the patient. It gives them green if it's a good image, or it gives them red if it's not a good image. It's quick. It's very, very quick. It's not steep at all.
That's good. Yeah, I've had those pictures taken, and it seemed like that the machine was helpful in telling the person when it was a good image or when they had to try it again. My next question was, I think that I heard you say that a lot of these machines that people bought were kind of collecting dust. And in my experience with telehealth, that has happened not just in this field, but in all kinds of fields. And I wonder if you were to say they're collecting dust because of these 2 or 3 reasons, what reasons would you give as to why they're not being used?
Yeah, it's usually the EHR integration piece. It's what's the word I want to use here? It's just the multiple times you'd have to do something. So with some of the solutions, you get an email, and that email will tell you there's a case waiting for you. You go in, you read the case, and then you fill out the report in their platform. So everything is on their cloud. And then you look at what your infrastructure wants in order to be able to bill it and all of this. So then you've got to put that in your EHR system. So you're repeating these steps. That was one thing IT thought was unnecessary, the duplication process and the time required. And some of the others just require putting in all of them require putting in an order, but if there's a mismatch between that order and your system, then it doesn't work. So our systems work that we have here because it's just DICOMs. DICOM is the universal language. You guys are more familiar with it than I am, but I do. Whenever I talk to IT, I say, hey, this instrument's DICOM compatible. And they're like, that's what we needed to know.
It's funny, it's true for all of telehealth. And that is one of the key components to ongoing use is it has to be frictionless. The technology has to be frictionless. And so much of the time it's not, and things aren't interoperable, so.
Yeah, thank you for that. Thank you. There are some solutions out there looking at teleoptometry, which is a whole new field that kind of picked up after the pandemic, but they are approved in more than 30 some states. They have vendor agnostic solutions that allow for the integration. But there's still some questions there. And I think, that's why I picked Teleretina. It's fairly frictionless if done right.
Yeah, it's pretty amazing. The difference between with the adoption of this new technology seems amazing. All right, does anyone else have Any thoughts on this topic?
Well, can we talk to could we talk to the Missouri Foundation for Health or some other funder like that to get these units in really high needs areas? Have you thought about that?
Well, we could, and we also know that there's this funding available through the Rural Citizens Access to Telehealth Project that we could think about, but we would want, Tareq, I think the state has some funding right now. If we were to say, I know that in the past you had talked to some health centers and thought through, and you probably know what the barriers are to partnering with some of the health centers. I think that would be good for us to know what in addition to the integration into electronic health records, what are some of the other barriers to the partnership between not just your organization, but other optometry groups and underserved Missourians to get this service?
That's a great point. Thank you. Not every optometrist, not every person's built the same. You can have optometrists that are very much against telehealth solutions, just like you have physicians in medicine. But that's that culture change that we're trying to build, because when you do talk about astronauts needing eye care, no one says, oh, you can't use technology there. But when you have people who have different barriers, but still barriers to getting into your site, what do? What do you want to do for them? We can't watch them suffer. And our students, I need to do a survey. So whoever wants to do a survey with me, please let me know. But like a pre and post survey, because the course feedback that we get is humbly outstanding after the course. But they'll say as I was getting into this course, I was hesitant, but now I understand that this is something that we need to do. So one of the barriers is the provider. No one will be on board. Well, few patients will ever be on board, but most patients will not be on board if the doctor's not on board.